This conference will now be recorded.
Okay, so we'll be starting with a new chapter today. Last time we finished the peritoneum, and this time we'll be starting with the pancreas. The usual disclosures and acknowledgements before starting a lecture, because a lot of material has been picked up from textbooks, internet, and other sources. Right. So first, let's come to the embryology because that's an important part of understanding a number of diseases of the pancreas. So it all starts with the development of two buds: the dorsal pancreatic bud and the ventral pancreatic bud. They appear for the first time in the fourth week. And if you look at this ventral bud, that is the ventral bud here, that rotates clockwise. This is a rotation clockwise, and then lies behind the dorsal bud. So the dorsal lies anteriorly, the ventral lies posteriorly because it's rotating clockwise. Can be better seen here. This rotating, and then it comes and lies out here, right? So this is the part which has been developed from the ventral bud, the lower part, and the rest is the dorsal bud, right? So the ventral bud forms the lower part and the uncinate process. That's the part which is formed by the ventral bud. And the dorsal bud, the rest of the gland, that basically means the body, part of the head, and the tail. They all are because of the dorsal bud. Okay, so that is basically, in a nutshell, the whole embryology, and which starts in the fourth week. Now, if you look at the anatomy of the pancreas, approximately 80 grams, and it's a truly retroperitoneal, one of the truly retroperitoneal organs. It's got peritoneum only on its anterior surface. It has got a distinctive yellow, tan, or pink color and is multilobulated. That's how it looks like. Now, the various parts you can have the head, you can have the uncinate process out here labeled. You can see 1, 2, and 3. 3 is the pancreatic notch, which gives way to the superior mesenteric vessels, the vein and the artery. You got the body, which is number 4. This whole thing is the body from here to here, and then you got the tail. Now, in between, there is what is known as the omental tuber. This is basically the anterior surface of the pancreas, which comes in contact with the lesser omentum, the posterior part of the lesser omentum. Then come the surfaces. You got two surfaces, rather three surfaces: the anterior surface, the inferior surface, and the posterior surface. Posterior surface is the retroperitoneal surface, coming in contact with the retroperitoneal organs, and the anterior surface is the part which comes in contact with the anterior part, namely the posterior surface of the stomach, the lesser omentum, and part of the transverse colon, so on and so forth. The margins, if you look at the excuse me, the margins, you got the superior margin labeled as number 7, you got the anterior margin labeled as number 8, and you got the inferior margin of the pancreas labeled as number 9. And here you got what is known as the duodenal sac. So this is basically the parts of the pancreas. Now going a bit further, the four portions, that means the head, neck, body, and tail, how do you divide them? The head is partly the part which is lying inside the duodenal sac. This whole thing forms the head, and then it includes the posterior inferior extension arising from the ventral primordium, that we just not said, that the ventral and part of the dorsal, because this whole part is developed from the uncinate process. This part is developed from the ventral, which has rotated clockwise. Rest is dorsal, right? Now the neck is that part which is overlying the superior mesenteric vein. So this is the part overlying superior mesenteric vein, and that is the neck. The body and the tail, they extend to the left of the body and extend up to the splenic hilum. It's made up of two important divisions. The first is the endocrinal compartment, the second is the exocrinal compartment. The major compartment by far is the exocrinal compartment, responsible for 80 to 90% of the pancreatic bulk, and it consists of the acinines, it consists of the ductules, the ducts, and the centroacinar cells. On the other hand, the minor part, about 10 to 20%, is the endocrinal compartment, which is organized into islets. See, these are the islets. So this is the ductular system. These are the SNI. This whole thing is the exocrinal part. And in between, you got these nests of cells known as the islets, and these are the endocrinal component. And the endocrinal component, the majority of cells in the islets are the beta cells, which make up almost 75% of the islet cells. And we all know that the beta cells are responsible for the secretion of insulin and amylin, and they form the inner core of the islet. That means the central part of the islet is formed by the beta cells. Okay. Now the alpha cells are 20%. They secrete glucagon. The two other major cells are the D cells or the delta cells, responsible for somatostatin, And it was the PP cells, or the pancreatic polypeptide cell, responsible for the secretion of polypeptide, making up 1%. So that makes it almost 100%. A very few cells are the E cells, or known as epsilon cells, and these are responsible for the orexigenic hormone secretion, that is ghrelin, which is also, if you remember, the last lecture, one of the previous lectures on bariatric surgery. I don't know if your batch was in the lecture or not. It's majorly secreted from the fundus of the stomach. But this is one other place where ghrelin is secreted, and that is the E cell. So the in a nutshell, there are four main types of cells in the islet cells. The majority beta, then comes the alpha, the delta, and the pancreatic polypeptide cells. A very small part is the E cells. Okay, so that is how it is arranged. Now, just a few words. We all know about insulin and glucagon. We'll talk about them on some later point of time. But just to mention the three important, or rather, I wouldn't say important, but three other hormones which are being produced at the level of the pancreas. And the ghrelin, I told you, the only hunger stimulating peptide, or exogenic peptide, primarily from the front of the stomach. I just not told you that, and also from the pancreas. That is responsible for your hunger. Whenever you feel hungry, you're basically under the effect of ghrelin. Then you got the self-regulated pancreatic secretion of the polypeptide. It also affects the hepatic glycogen levels and gastrointestinal secretions. And then comes the amylin, which is also secreted from the beta cells, which is islet amyloid polypeptide. Along with insulin, it is co-secreted with insulin from the beta cells in a ratio of approximately 100 parts of insulin to 1 part of amylin. That's 100 is to 1. And plays a role in the glycemic regulation, just like insulin has a slightly varied effect by slowing the gastric emptying and promoting satiety. So it prevents the postprandial spikes in blood glucose levels. So it is basically a hormone which is stabilizing your blood sugar level, right? Now, come to the microscopic anatomy of the pancreas. If you look at the microscopic anatomy, you'll see that this is the common bile duct, and it is joining the pancreatic duct out here. And here you got the main pancreatic duct, and you got the accessory pancreatic duct. That's the accessory pancreatic duct. And these ducts are basically, if you look at a enlarged picture of this particular part, you'll find that these are the islet, the acinis, and the ductular system, and these are the islets. Now, the islet cells are all drained by one single, or rather drained by a venous system directly into the portal system, right? So, whatever is secreted in the islet goes into the portal system. The acinar cells, they would drain into the ductulars, and we'll just talk about the levels of the ducts, and they ultimately go into the pancreatic duct. So, that is at the level of the ductular system. That's how it looks like. Okay. Now, coming to the exocrinal anatomy of the pancreas, if you look at this figure, you will see this is the acini, and here the red are the centroacinar cells. Now, the centroacinar cells are nothing but the cells from where the ductule starts. That is from where the ductule starts. So, you got the acini. The acini has got these cells which are resting on a basal lamina. So, you got a basal lamina, and you got the acinar cells. And inside, what do you find? You find the collection of enzymes. All these cells which are here, which are the basal cells, these are rich in zymogen granules at the apex. So this is the apex of the cell. So you have the Golgi apparatus and the zymogen granules all localized at the apex of the acinar cell, right? The central acinar cell, just now told you, is the starting point of the terminal ductule. Then you got the intercalated. Let's go to this figure. Now from here the SNI, now you got the intercalated, also known as the intercalary duct or the terminal ductules, which then is a portion of the exocrine gland leading directly from the SNS to a striated duct. It then goes and opens into the intralobular duct. From the interlobular duct, it goes and opens to the interlobar duct, and then ultimately it goes to the pancreatic duct. So you have the difference in the epithelial lining, which changes from a very thin epithelial lining, which is a flat epithelium in the interlobular part, to cuboidal, and ultimately to columnar epithelium. So flat epithelium to cuboidal epithelium to columnar epithelium, which has got importance when we talk about the malignancies of the pancreas. So that is at the level of the basic exocrinal component of the pancreas. Now, the duct, so these are now opening the interlobar duct. So, from the intercalated, it went to the interlobular, the small and the large interlobular, to the interlobar ducts, and from the interlobar duct, then it goes into the main duct. And when you talk about the main duct is known as the duct of Wilson, and it has got two parts to it. Part of it is what was the dorsal pancreatic bud. See, this hole, the accessory pancreatic duct and distal part of the duct, or rather I should say proximal part. Let me correct myself because the duct starts here, ends here. So this would be the proximal part. So the proximal part of the duct is basically the remnant, or I shouldn't say the remnant, it is derived from the dorsal bud. The rest of the dorsal bud duct remains as accessory duct. So what happens in between? The ventral bud which had come to lie behind the dorsal bud forms the rest of the duct of Wilson. So the duct of Wilson proximal part by the dorsal bud, the distal part by the ventral bud. Is that clear? And this ultimately is going to drain at the ampulla of Waiter. Now, it may or may not be connected to the accessory duct. There are a number of variations of the ductal anatomy, but the distal part of the dorsal bud duct remains as the accessory duct. And that accessory duct you opens at a separate papilla, and that is the duct of Santorini opening at the minor pancreatic papilla. It may or may not be connected to the duct of Wilson. So that's the ductal anatomy. So now we know that the main duct of the pancreas is partly from the dorsal, that is the proximal part dorsal, and the distalmost part is from the ventral bud, which was the rotated part of the pancreas. Okay, so that is how the duct of Wilson is built. Now, there is a number of variation ductal in the anatomy. 60% of these, 60% is what we are looking at. That's the normal pancreatic ductal system that we just now showed in that figure with a minor connection out here. That occurs in 60%. But in the rest 30%, there is separation of the accessory duct, and in 10%, you have a separation of the main duct. That means you have a separation, let's say the 10%. So here see what is happening. This is what is happens in a congenital condition known as pancreas divisor. So here the Wilson, the duct of Wilson, basically the distal part which was supposed to be derived from the ventral bud, either does not make connection with the main duct, see, or the Wilson branch is very small branch out here, or there is a full connection, and the duct of Santorini also acts as the major outlet. So three parts to the separation: main outlet, or disconnection, or duct of Wilson absent except in only the proximal most part. The separation of the accessory duct, either duct of Santorini does not connect to the minor papillae, or it connects to minor papillae but there is no connection with the main duct, or it is absent totally. So these are the variations in the ductal system of the pancreas, which has an important role to play in the applied diseases, right? Now, if you look at a overview, the duct of Wilson, because the distal part is coming from behind, so it is always in a posterior plane extending from the tail to the ampulla of Vater. The duct of Santorini, because it is arising from the dorsal bud, which is lying anteriorly here, so it would be in a more anterior plane, right? Now, what is important about the minor papillae is the location of minor papillae is important. It is located 2 centimeter proximal to the major papillae and 7 centimeter from the pylorus. Remember that, that is very important, right? So 7 centimeter, important for what? Important for the endoscopist. He has to identify the minor papillae often. So he should know where the minor papillae is lying. A major papilla where the duct of Wilson is opening is easily identifiable. So 2 centimeter proximal to it, or 7 centimeters approximately from the pylorus, you will find the minor papillae. Now, another landmark for the minor papillae, especially when you're going in for laparoscopic surgery or you're doing open surgery, is identifying the gastroduodenal artery. The gastroduodenal artery always passes proximal to the minor papillae. And this vascular landmark is very, very useful when you're doing a partial gastrectomy, the distal partial gastrectomy, and you have to transect the first part of the duodenum. In these instances, you have to identify where the gastroduodenal artery is lying. Why? Because you don't want to go too distal in the duodenum and ligate and close the duodenum. Otherwise, you may be injuring the minor papillae. So you have to identify the part of the minor papillae, gastroduodenal. Stop at the point of gastroduodenal. Don't go distal to that. Now, the ductal diameter is also important because on ultrasonic or MRI or CT, whatever, method you choose to define surgical anatomy, will come to which is better. You would naturally look whether the pancreatic duct is dilated or not. So for that you should know the approximate sizes. So a mnemonic is 432. But to be more exact, as you go from distal to proximal, distal means this is in the region of the head, 3.5 millimeter. Remember it as 4, body 2.5, remember it as 3, tail 1.5, remember it as 2. 4, 3, 2 is the easy method remembering. If you want to be more exact, 3.5, 2.5, 1.5. Remember, there has to be number of variations, and that's why until unless you have a diameter of more than 7 millimeter, you never call it a dilated pancreatic duct. These two facts are important. So for dilatation, to say the pancreatic duct is dilated, you should have a diameter of at least 7 millimeters, and otherwise the normal diameter is 432 or 3.5, 2.5, 1.5 to be more exact. Now, pancreas divisum, we just not talked about that. There are three types to it: classic, absent ventral duct, and functional. These are the three types. You have the classic, where there is no connection at all, occurs in majority of cases. There is no connection here in pancreas divisum. 70% of pancreatic divisum, they do not have any kind of connection. You can have an absent ventral duct, like example in G, there is absent ventral, so this duct is absent. This was the part to be made by the ventral bud, so that is absent. And you can have functional, where you have a very filamentous attachment between the two, found in 5 to 6% of cases. Now, this is basically pancreatic divisum is basically occurring because of malfusion between the dorsal and the ventral ductal system. Very easy to understand. And it can also result in a dilated cyst-like formation, or the Santorini seal, which is cystic dilatation of the distal dorsal duct, immediately proximal to the manna papilla. So here in this region, you can often find a cyst in those cases where there is no junction between the two, and you can find a cyst in this particular area known as Santorini seal. Now, how does the duct open? It opens at the ampulla, and the ampullary anatomy is important. This part of the anatomy we have already talked about when we talked about the CVD. If you remember, the proximal and the distal choledochal sphincters, the common ampullary sphincter number 3, and this is the pancreatic sphincter, right? Now, in 67% of cases, you have what is known as the typical ampulla, 1 to 3 centimeters long. 30% of cases, you would have opening adjacent to each other, and in 3%, you will have distant opening. That means you'll have two openings in the region of the ampulla, two ducts opening absolutely separately, right? Now, this is a junction of the bile duct and the duodenum. Look here, this is the sphincter of the pancreatic duct, and is reinforced by the muscle layer of the duodenum. See, these are reinforcing fibers, duodenal muscle fiber, longitudinal and the transverse muscle coat of the duodenum reinforcing these muscles. So this is the proximal and the distal choledochal. This is the CBD, proximal and distal choledochal. You've got the ampullary sphincter, and you've got the pancreatic sphincter. This was a very good figure. I picked it up so to make you understand it better, right? Now, coming to the posterior relations, I told you the posterior surface. So the pancreas primarily lies at the level of L1 vertebral level, and it's got a lot of important structures posteriorly. Very important when you're trying to dissect out the pancreas to do any kind of pancreatectomy, whether it's a distal pancreatectomy or it's a proximal pancreatectomy or removal of the head of the pancreas, or you're doing a complete pancreatectomy, what is known as the Lupus operation. So in any case, whatever kind of excision of pancreas is being thought of, you have to be very careful about the anatomy, which is posteriorly related. See here, the major vessels, you got the inferior vena cava and aorta. But more important than that, you have the superior mesenteric vein, which is curving over the pancreatic notch. This is the notch, and lying over the uncinate. Remember, this is the uncinate process. So that is one of the very important structures. And further to the left lies the superior mesenteric artery. So the mesenteric vein and artery, which are very important structures to be very carefully dissected off. And the second structure very carefully dissected off. See what's lying out here, the portal vein. Equally important are the splenic vein and its tributaries out here, and the inferior mesenteric vein. So a lot of major vessels lying out here. The kidney does not pose a problem. The ureter doesn't pose a problem. Even the hilum doesn't pose a problem, where the tail of the pancreas is reflected, except when you're going in for a splenectomy, the chance of injuring the tail of the pancreas and leading to pancreatitis. So the whole anatomy is very important in as much as the vascular posterior relations are concerned. So remember, this is a very important part if you're planning any kind of pancreatic resection, any kind of pancreatic resection. Okay, and if you're doing a splenectomy, the tail of the pancreas gets an added importance. Now, coming to the blood supply of the pancreas, the major blood supply comes from the two pancreaticoduodenal arteries, the superior, which is a branch of the gastroduodenal, and the inferior branch of supramesenteric. And both of them divide into anterior and posterior. See here, the anterior and the posterior. So the posterior makes an arcade, the anterior branches join together make an arcade. So you got an anterior arcade or pancreaticoduodenal and posterior pancreaticoduodenal arcade, which are being made by the superior pancreaticoduodenal and the inferior pancreaticoduodenal, ultimately coming from superior mesenteric and the gastroduodenal. The body and the tail. So this whole is supplying the head and the neck. The body and the tail is basically supplied by, see, which is the special, the splenic artery. And what is lying out here? The stomach. So you got the right gastroepiploic out here, the right gastroepiploic. So it is the gastroepiploic which is lying here, and the dorsal pancreatic, and the splenic artery, which are basically supplying the major part of the pancreas. There is another vessel which is the dorsal pancreatic artery, which is a branch of the splenic artery, which is making another arcade and a transverse pancreatic artery supplying the posterior part of the body. Right now, why is this vascularity important? Because pancreas is a very, very vascular structure. And the moment you start contemplating doing any kind of pancreatectomy, you have to be on a guard for messy hemorrhage if you're not careful about the veins and not careful about the arteries. Right? Now, what is equally important is the common blood supply to the duodenal C and the pancreatic head. See, these pancreaticoduodenal arcade, the anterior arcade and the posterior arcade, apart from supplying the head, it's also supplying the duodenum. So if you're contemplating removing the head, you have to perforce remove the duodenum. Why? Because if you remove the head, the whole of the blood supply to the duodenal C will also be cut off. You ligate this vessel here and you ligate this vessel here. You cut off the blood supply of the whole duodenal C. And that is why when you are talking about Whipple's operation, what is the name of the Whipple's operation? Pancreaticoduodenectomy. Not because you want to remove the duodenum, but because you have to remove the duodenum because the vascularity would suffer. And that's why now they have modified Whipple's operation where you leave a rim of the pancreatic head behind if you're doing it for a benign condition. Would not be possible for a malignant condition of the pancreas. But if you talk about a benign pancreatic condition, you may leave a rim of the pancreas and then you can save the pancreas. That is the duodenal sparing Whipple's operation. Okay. So these facts are important, these vascularity. Another important point is that the superior mesenteric artery is the hepatic artery may often arise from the superior mesenteric artery. So the hepatic artery rises here, right? This is hepatic artery. There could be an anomaly where it's arising superior mesenteric. So if the hepatic artery is arising from this part, where is it going? It would go like this. So it is going to pass behind the is going to pass behind the pancreas and the CBD. The CBD is here, it's opening here. So the hepatic artery is going from here and then approaching here. It may either pass through the substance or lie truly posterior to it. And it may be related to the superior border of the pancreas. And that is important that when you're doing any kind of pancreatectomy, be careful that you may not ligate an aberrant hepatic artery. You have to be very, very careful. Right? And we already specified the gastroduodenal artery may be is lying proximal to the minor papillae, and it has to be landmark where you do not go in for duodenal dissection beyond that point. If you do, then you're cutting on the minor papillae. Coming to the blood supply and the venous drainage is mainly by the splenic vein, the inferior mesenteric vein. They go and open into the inferior mesenteric vein, opening into the superior mesenteric vein, and together they form what is known as the portal vein. I said earlier, the islet always drains into the portal vein directly. So you have got the main venous outflow to the splenic, the inferior mesenteric, together forming the superior mesenteric, and then ultimately into the portal system. As far as the lymphatics are concerned, it's got a very wide lymphatic drainage. These are those lymphatics lying in the head region and lymphatics lying in the body and tail. If you look at the head region, you got the pancreaticoduodenal opening into the subpyloric. You got mesenteric out here, and you got the portal lymph nodes out here, the mesocolic and the aortocaval caval lymph nodes. Because remember, the aorta is lying somewhere here. The body and tail, on the other hand, would be pancreatico-ileal glands, the splenic group of lymph nodes, the cilia group of lymph nodes, and the aortocaval or the mesenteric lymph nodes. So what I'm trying to put across is that the lymphatic vein is so wide that you cannot identify one group where the lymphatic metastasis is going to occur first and then go to the second. So it is a wide dissemination lymphatic spread of a malignancy. The nerve supply, parasympathetic and sympathetic. The parasympathetic supply both the vagi, which have got their ganglia inside the pancreas, so intrapancreatic ganglion, and they are basically supplying two types of fibers: the secretory fibers for the exocrine, mainly enzymes and volume secretion, and the motor fibers are for the smooth muscles in the major ducts, which propel the pancreatic secretion on into the duodenum. You got the sympathetic supply. These fibers are cholinergic, as in eccrine sweat glands. That means sympathetic fibers secreting acetylcholine. That's why they're known as cholinergic sympathetic fibers. Otherwise, sympathetic, supplies what? Adenoidally. Thoracic outflow through the greater, lesser, and lowest splanchnic nerves. So how do these sympathetic fibers reach the pancreas? Through these three nerves: the greater, lesser, and the lowest splanchnic nerve. And it's mainly concerned with the pain fibers. If you look at the physiology, the final secretory product of the human exocrine is a clear isotonic solution with a pH in the range of 8 to 8.4, which is a highly alkaline solution. A specific gravity that varies from 1.07 to 1.035. There are two distinct components to it. One, the enzymes which are arising from the acini, right? And the water and electrolyte arising from the intercalated duct. So here the intercalated duct and the ductless system, right? So centroacinar from here, intercalated, the interlobular, and then ultimately into the. So that is the exocrinal physiology, the secretion occurring as an alkaline, clear secretion enzymes. So the water and electrolyte is one component, the enzyme is the second component, exocrinal. So if we look at the water and electrolytes of an exocrinal component, it goes under the vagal and the humoral control. Vagus is supplying both for the enzymes and water electrolytes, but primarily, if you look at the water and electrolyte part of the pancreatic secretion, it is largely determined by the secretion of secretin from the jejunal mucosa. And the most potent endogenous stimulant to pancreatic bicarbonate, right? So it is lead to secretion of what? The bicarbonate electrolytes from where? Primarily centroacinar cells and the intercalated ductal cells. Remember that first figure we showed you? Okay, so these are the two primary sites. In rare circumstances, if the pancreas has been stimulated more, even the acinar cells, apart from the enzymes, can start secreting the bicarbonate and the electrolytes. So daily about 1.5 to 2.5 liters of pancreatic juice. pH we just now told you 8.0 to 8.4. Bicarbonate content is very high, anywhere between 25 to 170 milliequivalents per liter, right? Sodium similar to that of plasma. The secretion is mainly an active secretion, active transport system which exchanges chloride with the bicarbonate. Let's not go into more details. That is enough for you to understand. The second component, apart from the water alkalis, now is the enzymes. So these were coming from where? The water electrolytes from the centroacinar cell, that means at the starting point of the ducts, and the intercalated ducts. So these were the parts from where the primary secretion of water electrolytes occurs. Now, where does the primary secretion of enzyme occur from? Obviously, the acinar cell. And how does it occur? Here also, stimulation of vagus. But here the hormonal stimulation is different. There it was secretin from jejunal mucosa. Here it is pancreozymin or cholecystokinin secreted from the duodenal and jejunal mucosa. Most potent endogenous hormone for pancreatic enzyme secretion. Secretin was the most potent for pancreatic bicarbonate. Cholecystokinin pancreozymin is from the duodenal mucosa and most potent for pancreatic enzyme secretion. So what is really happening at the level of the acinar cell? The Golgi apparatus, the enzymes start forming. They migrate to the acinar cell apex. I showed you that in that particular figure. The Samogen granule membranes fuse with the acinar cell membrane, undergoes exocytosis, yielding extrusion of the Samogen granule into the luminal space. That is, now they're lying inside the SNR lumen. And from the SNR lumen, now they start shifting to the ductular system, right? Now, they contain a full complement of digestive proenzymes to the extent of 6 to 20 grams of enzymes enter the duodenum daily. And they are always in the form of inactive, that is, they are proenzyme. Because remember, if they are activated at this point of time, they would lead to be, they would occur what? A destruction of the pancreatic cells, ultimately the cause for acute pancreatitis. Remember, the secretion is always in the inactive form or the proenzyme form. Now, what are the enzymes we're talking about? The proteolytic enzymes, the enzymes which are amylases, and the lipolytic. So these are a whole range of protein breakdown enzymes, the fat breakdown enzymes, and amylase. I'm not going to go into the details. You can just read it up, right? Okay. Now coming to the control of secretion. So we said that these are the hormones and the vagus. So together you can talk about the various phases: the cephalic phase, the gastropancreatic phase, and the intestinal phase. So are these the only stimulants, the secretin, the pancreasomin, and the vagus? No, there are other stimulants also. Right in the cephalic phase, you got the smell, sight, taste of food. They all are going to stimulate your pancreatic secretion. In addition, there could be gastric secretion, which causes duodenal acidification. The moment the duodenum gets a high acid output, immediately the pancreas gets the call, send some alkali, I want to utilize the acid. So that stimulates the secretin release and subsequent pancreatic bicarbonate secretion. So in the net effect of the cephalic phases, that you have a secretion of enzyme-rich bicarbonate-rich fluid at the level of the pancreas into the duodenum. The gastropancreatic reflex, the second method, this mediated probably by gastrin, which stimulates the volume and enzyme output from the pancreas. The third is the intestinal phase. And intestinal phase, we know about the CCK and secretin, which are stimulated from the jejunum. Agreed, they are the major factors, but the other factors also. One, the hydrochloric acid entering the duodenum. Second is release in circulation and leads to the secretion of bicarbonate. But what about the other nutrients? Nutrients, they exert direct or indirect regulatory effects on pancreatic cells. So you got amino acids, which stimulate exocrine pancreatic secretion. You got intraluminal fatty acids stimulating, and to a lesser extent, glucose. So that basically what you're trying to tell you, that even the partially digested food is a stimulant for the secretion of both enzyme and the electrolytes at the level of the pancreas. And then they have got paracrine stimulators. Now coming to the investigations of the pancreas. For the pancreas, that part of the anatomy, I think that part of anatomy and physiology is enough to understand the further disease processes. Let's talk about the investigations. When you talk about the investigations, one, you're trying to look at the exocrine function. And how do you do that? Number one, you can look at the pancreatic enzyme levels in the body fluids and the blood. More importantly, serum. You can also tap on these pancreatic enzyme level at the level of the duodenum, or you can also look at these levels in the body fluids, right? Then you can look at the bicarbonate in the pancreatic secretion, right? Pulmonary function test can be done. You can have a morphological abnormality can be depicted, and for that morphological abnormality depiction, you have a whole range of investigation. You can have an ultrasound. You can have a CT scan, a double contrast or a triple contrast CT scan, which is enough to define 1 to 2 centimeter. You can also add triple contrast here, double contrast and triple contrast both. The triple phase, which is known as the abdominal CT, triple phase abdominal CT, is the gold standard for evaluation of acute pancreatitis and other pancreatic pathologies. Then you can have a MRI and combine it with the MRCP. You can have a PET scan. You have the ERCP, and you got the endoscopic ultrasound. We'll not talk about the details of these investigations at this point in time. They will be dealt with in each disease process. But just a few words which are important at this point of time. And then serum amylase, which is probably one of the most important enzymes to be looked at when we talk about acute pancreatitis. Now, the thing about serum amylase is that it is not 100% diagnostic. The third line, it is not prognostic. What does that tell you? Usual practice in the emergency ward is your resident orders serum amylase when the patient comes for the first time, probably acute pancreatitis, good. And third day he asks you, should I get a serum analysis repeated? He asks you why. He says we could judge whether the pancreas is proceeding in a more severe or a less form. No, the MLAs is never prognostic, a prognostic indicator, and it is not a 100% diagnostic indicator. What is required is there should be elevation of 3 times. But the prime question is, when should the amylase be elevated? Now the patient has an attack immediately, let's say 8 o'clock in the morning, and you get a amylase level done at 12 o'clock in the morning, suspecting acute pancreatitis. Do you believe the amylase would rise at this point of time? No, it would not. Starts rising 6 to 8 hours, peaks at 48 hours, declines after 4 to 8 days. These things are very, very important. This chronology is very, very important when you talk about serum amylase. And the other thing important is, when would you say serum amylase is probably indicative of acute pancreatitis? I say probably indicative. Why? It is not confirmatory. And that also when there is a 3 times rise in the baseline level of serum amylase, which is somewhere in the region of 53 to 123 units per liter, right? Urinary amylase and amylase creatinine ratio were initially touted as very good parameters, useless parameters. You can forget about that, right? So just remember amylase, but amylase just to be remembered because it still forms one of the investigations, despite the fact it has got a very low specificity and very low sensitivity. I'll just show you in the next slide why. But probably what is more specific is serum lipase. Again, a more than 3 times rise in the level, more sensitive and more specific acute pancreatitis. So if you ask a single enzyme to be study to be done to diagnose acute pancreatitis, your answer should not be amylase, it should be serum lipase level. Is that clear? It is important. Now, the other thing is stool elastase level. Absence of stool elastase shows exocrine insufficiency. So again, these are this is a indirect parameter. Now, the why did I say that amylase is not a very good parameter? Is perhaps one of the lesser important parameters, because see the whole range of conditions where you'll find a raised amylase level, starting from two important organs, pancreas and salivary, right? The third cause could be a decreased metabolic clearance of amylase, which is cleared out at the level of the liver and the kidney. So you got any kind of decompensation, you got any kind of liver decompensation, you'll have a raised amylase level. That doesn't mean the patient got pancreatitis, right? In pancreatic conditions, it's not only acute pancreatitis, raised amylase level. You do chronic pancreatitis, cirrhosis of pancreas, pancreatic ascites, trauma, you got a choledocholithiasis, you can have a post ERCP rise in amylase. Salivary causes again a second group of important causes. So you have post radiation saliva to the neck, they will increase the amylase level. Salivary gland calculi, or you got a trauma to the parotid region, a raised amylase level, right? Other known etiologies where you can have a raised amylase level, you can have macroamylasemia, any kind of intestinal catastrophe, intestinal perforations, intestinal volvulus, peritonitis, mesenteric artery thrombosis, right? So basically, any ischemic condition or inflammatory condition of the bowel can give rise to raised amylase level. Then female reproductive tract disease, like for example, ruptured ectopic, fallopian ovarian cyst, salpingitis, malignancies right from lung, ovary, pancreas, so on and so forth. Acidosis, with or without ketoacidosis, and then of course balloonicid enteroscopy. So this whole list of conditions tells you that there is a wide variety of disease processes which can give rise to raised amylase level. That's why I just now said that acute pancreatitis, one single enzyme to be named is lipase, not amylase, because amylase is very, very non-specific. Coming to the pulmonary function test, PFT, pulmonary function test. So you're looking at the exocrine function. Either you can do a direct measurement or you can do an indirect measurement. I'm not going to go into the details of this. I'll just uh, label it for you. They are not very important in the sense that they're not routinely done under clinical conditions. It is more for experimental or condition for thesis or things like that. So you can have a direct measurement of the output from the duodenum by stimulating duodenum. Either you stimulate it with a physiological stimuli, that is, you have a standard meal known as the Lund test, or you can do a pharmacological stimulation of pancreatic secretion by giving this patient IV secretin or pancreasamine, and you put in a tube, a triple lumen tube inside the stomach. Why triple lumen? Because you don't want the duodenal secretions to be mixed up with the gastric secretions. So that triple lumen, one lumen is inside the stomach, the second lumen is inside the duodenum, and the third lumen the esophagus. So you're basically segregating from the duodenum, you just collecting the duodenal, right? And duodenal juices are to be aspirated, and a non-absorbable polyethyl glycol is a marker to see the completeness of aspiration. So until you have output of PEG, the duodenal secretion is still present. Once PEG stops coming out, that means you have completely aspirate duodenal juice, and then do the further study of estimation of the volume and the enzyme content, the bicarbonate, and so on and so forth. The indirect measurement could be done with the nitro-blue tetrazolonium para-amino acetic acid, benzoic acid, sorry, not acetic acid, benzoic acid can be given orally, and it is broken the gut by the pancreatic enzyme. So here you're looking indirectly creation of PABA, and this is absorbed and excreted in the urine, and you can do a urine level measurement. So you just have to give a oral capsule and measure something in the urine. That's why I say indirect measurement. The second is the pancreas test. These are non-specific tests. That's why the indirect measurements, especially post-gastrectomy, altered intestinal transit time, altered intestinal absorption. So what is happening? You're giving a capsule. So that capsule would release a particular substance to be absorbed. So if the absorption is deficient at the level of intestine or stomach, or the transit of that substance to the distal part is affected, so this test would become inconsequential. That's why if a post-gastrectomy, altered transit time, altered intestinal absorption, in all these conditions, this indirect measurement becomes superfluous and absolutely useless. The more specific could be stool elastase level, which you referred to, and low level indicates exocrine insufficiency. Pancreas test, I think you can go and read it up. There's basically two parts to it. There's a control, which is giving free fluorescent capsules, and there is a administration of oral fluorescein ester, that is dilaurate ester, which is broken down by a pancreatic enzyme. I'm just telling you the principle. That enzyme is the cholesterol ester, so that breaks this ester hydrolase, breaks this compound of fluorescein, which is the ester, and this cleaves and releases fluorescein. So here the fluorescein being released inside the body by an enzyme from the pancreas. So in essence, that is telling you about the function of the pancreas, right? And this fluorescent will then be excreted in the urine fluorescent. So it would depend upon what? The ester which has been taken, it has to be absorbed through gastrointestinal absorption. Then it has to be excreted into the kidney, renal excretion, as well as exocrine pancreatic function. So the control is a free fluorescence. So that circumvents what? The circumvent the exocrine pancreatic function. That forms a control. So if there is a difference between the two, that is the TK ratio, that is used to estimate the digestive function. So you just remember the principle of a pancreas test. The other investigations, the ultrasound, initial investigation of choice, but it provides indirect info. Not a very good investigation, but still the investigation, the first investigation of choice. But it doesn't tell you too much about the pancreas. It's just going to tell you about the related diseases. Like, for example, it can tell you about, let's say, a gallbladder stone disease, and you're suspecting acute pancreatitis. So that gives you an indirect hint that probably there could have been a CBD stone, or there are liver mets in a patient with pancreatic cancer, or the cyst in a pancreas. So these are instances where ultrasound is going to help you in a pancreatic disease. The second is the CT scan, which is the gold standard, especially the triple phase CT. Triple phase, why? Because the first phase is a non-contrast CT looking for the calcification of gallbladder and pancreas. The second phase is a two-phase CECT with IV contrast, the arterial phase, the venous phase. So together these make the three phase, the triple phase. NCCT, the arterial phase CECT, and the venous phase CECT. And in addition to this, what else? The stomach and the duodenum has to be visualized by distending them and outlining them with fluid, that is water. So that tells you about a number of other of important conditions. It can diagnose lesions as small as 1 to 2 centimeter. It can tell you about the degree of necrosis and acute pancreatitis. It can tell you about inflammatory collections, like for example pseudocysts of pancreas. It can also be used for therapeutics. A CT scan can be used for therapeutic, for guided aspiration, for a percutaneous needle aspiration or a true cut needle biopsy, right? An MRI with or without MRCP is a very good investigation for delineating the ductal system in a non-invasive way. An invasive depiction of the ductal system occurs with a ERCP, but that is the invasive method. Here you're looking at a non-invasive method for delineating the ductal system and anatomical delineation of the whole duct. ERCP gives you the ductal anatomy. It tells you about the calcification. It also tells you about the aspirate. You can aspirate, and that aspirate can then be subjected to a pap staining, brush biopsy, and you can also put in a stent. So it is both therapeutic and diagnostic. That is where it scores over MRCP, which is only diagnostic, it is not therapeutic. And then, of course, one of the very important investigations as of now, and that is the ultrasound guided, that is, endoscopic ultrasound. EUS is endoscopic ultrasound. And that defines the vascular and ductal relation. That is very, very important. Has become an important part of armamentarium of pancreatic surgeons. Why? Because you want to do any kind of pancreatic lump excision, you have to know about the relation of that lump to the ducts, the relation of the lump to the vessels, and that is very easily seen on a EUS. So it defines the ductal relations of any pancreatic tumor, and it also defines the vascular relations of the tumor, and it also guides transdutal and transgastric fine needle or true cut needle biopsy. That is basically in a nutshell about the investigation. Now coming to congenital anomalies, the three anomalies we'll talk about is the ductal pancreas divisum, annular pancreas, cystic fibrosis, and bifid pancreas. First, let's talk about cystic fibrosis, which is autosomal recessive disease. The incidence varies anywhere from 1 to 3,200 population in the Western world. To Asians, it is 1 is to 30%. So 30,000. So what we're looking at is a disease primarily in the Western hemisphere, the Western world, less in the developing world or of the Asian world, right? Sex, equally male females, but in females there's one thing, and that is female with cystic fibrosis would have a greater deterioration of pulmonary function with increasing age and younger mean age at the diagnostic level or mean age at death. Six classes of mutations occur. So what is the cause? The cause is the congenital fibrosis transmembrane regulator gene on chromosome 7, that is CFTR gene. And there are six classes of mutations. There are almost more than 1,000 mutations of this gene in cystic fibrosis. They have been grouped into classes. So you've got six classes of mutation defects in this gene, which is controlling what? The transmembrane movement of the chloride ion, known as the congenital fibrosis transmembrane regulator gene, CFTR. Now, the CFTR mutations have got a poor penetrance. That basically means that the genotype, that means if you look at the genetic structure, it does not predict whether the pattern of the disease is going to be severe or mild. So, just doing a genetic study in a patient would not tell you about the clinical manifestation. It tells you, yes, the disease is present. It will not tell you about the degree of clinical manifestation in that particular patient. Now, what does the CFTR gene do? Now, the defect in the CFTR gene leads to decreased secretion of chloride, increased absorption of sodium and water across the epithelial cell. So, what is happening in the epithelial cell? There is a reduced height of epithelial lining fluid and decreased hydration of mucus. So, mucus becomes thick and viscid and stickier, and this viscid mucus tends to clog inside the ductals. So, the bacteria stick to the surface. This is very difficult to clear, and the duct gets blocked by the viscous secretion. All this leads to what? Clogging, infection, inflammation. Okay, and occurs where it involves a majority of exocrine glands. So it's going to involve the pancreas, the sweat glands, the bronchus, the intestine, that means the lung level, the intestines, and the liver gland. In the pancreas, you have a ductal precipitation of secretions, leads to duct ectasia, fatty replacement exocrinal acinar tissue. So what is happening is that the acinar tissue now tends to get replaced by fat. Why? Because there's a blockage of the duct, the acini go into disuse and they atrophy. And the islet cells are the last to suffer. So you have very late endocrinal manifestation in cystic fibrosis. In about 10% of patients with cystic fibrosis, you may have a normal pancreatic exocrinal function because it's a mild form of disease. Intestine, very characteristic presentation of meconium, ileus, and a thick meconium in patients. Very severe meconium ileus, less severe, just thick meconium, and found in 7 to 10% of patients with cystic fibrosis. The pulmonary manifestation occurs in 90% of patients. See this, very important. So the two common manifestations of cystic fibrosis, number one is pulmonary, number two is pancreatic, right? Not in that order, of course, but pancreas and pulmonary. Pulmonary, 90% of patients are having some kind of pulmonary problem starting in the beyond the neonatal period also, even the neonatal period, but even beyond, you can have bronchus and bronchial obstruction in the form of cough, emphysema, finger clubbing, cor pulmonary at the later stage or end stage pulmonary disease. Liver, you can have bile duct plugging, causes portal hypertension. Genitourinary, males have got undescended testes, hydrocele, absent, vast difference. In females, you got amenorrhea and decreased fertility. And the patient, when kissed, would give a salty kiss. when the cheek of the child is kissed, you will feel all salt, and that is because of sodium and chloride in the sweat. Clinically, the median age at diagnosis is 6 to 8 months. However, age at diagnosis varies widely. Clinical manifestations vary with the patient's age and presentation. Two-thirds of these patients could be diagnosed by 1 year. In a newborn, the most common presentation meconium ileus, really NSACA. When a child is less than 1 year and comes to you for the first time, he will be coming with wheezing, coughing, recurrent RTI, pneumonia. An older child manifesting for the first time with cystic fibrosis coming to you for the first time would be showing a history of steatorrhea from birth, the rancid stools, which are very offensive stools because of the fatty acids getting decompensated, poor growth, protruding abdomen, clubbing and recurrent respiratory tract diseases, and delayed sexual characteristics. In the adults, the manifestation of cystic fibrosis in the form of infertility because of absent of vas deferens and the female thick cervical mucus, which prevents the cells from traveling into the uterus. Asymptomatic is a group of patients who are heterozygous carriers and may develop acute pancreatitis later in life. So these are the varied presentations of cystic fibrosis. The diagnosis, the requirements include either a positive genetic testing for CTFR mutations and a positive sweat chloride test finding, where you should find a chloride level more than 60 milliequivalents per liter. And in addition to these two, one of the following: a typical chronic obstructive pulmonary disease or a documented exocrine pancreatic insufficiency. I told you the two organs most commonly involved, and or a positive family history, usually an affected sibling, that the brother or the sister affected. A screening is very important in highly suspect families, and here in the prenatal screening, the parents' buccal brushing cells for CTFR gene analysis is a good method of deciding whether the child is going to be affected with CTFR or not. Amniocentesis for CTFR mutations, the amniotic fluid can be taken for analysis, and a neonatal. Now, this was prenatal. In the neonatal, immunoreactive trypsinogen, that is IRT, as the primary screening for cystic fibrosis is the mainstay of diagnosis, right? Others could be doing a chest X-ray, a CT scan of chest, the ultrasound for barium contrast enema, depending on manifestation, so on and so forth. These are just additive investigations. So apart from all these, the most important investigation is genetic testing for CTFR mutations and looking for features of exocrine pancreatic insufficiency and delineating pulmonary compartment involvement. The treatment goal is simple: maintaining the lung function as near normal as possible, control the infection, physiotherapy, clear the airway. Nutritional therapy has to be given. Why? Because the pancreatic enzyme secretion has suffered. So give this patient enzyme supplements, give this patient multivitamins, mineral supplement to maintain adequate growth. Low fat diet is important. Why? Because no fat digesting enzyme is remaining in the body. The pancreas is not producing any fat digesting enzyme. Increase amount of salt is given. Why? Because it's a sodium and chloride losing disease. And then, of course, managing complications, even up to the stage of doing a lung transplantation, may be required. The indication for surgery. So, where does the surgeon come in a cystic fibrosis? Where do we as surgeons come in? Respiratory problems, where surgeon is required, the patient present with pneumothorax, massive recurrent or persistent hemoptysis, or nasal polyps. If your patient has got a GI tract complication, like example meconium ileus, the most common manifestation of cystic fibrosis where the surgeon is required to intervene. Intersusception, gastrostomy tube placement for supplemental feeding, and rectal prolapse are all those instances where the surgery may be required in such instances. Right? Prognosis, it's a life-limiting disease. That's very important. 80% survive beyond 19 years. The average age as of now is around 40 years in developed countries. Around 40 years. That is the median survival in developed countries. And that also if you have proper control of a patient with cystic fibrosis. The annular pancreas is a pancreas where there is deficient rotation of the ventral part and fusion of the ventral part. Occurs in 1 is to 20,000 instances. Variation with partial or complete surround the duodenum with pancreatic tissue. So here there is a deficient. Deficient in the sense that the ventral part remains there, dorsal remains there, and instead of the whole ventral going behind and sticking and the rest of the circumvallate duodenum remaining free, there is a circumferential, either partial or total circumferential pancreatic tissue surrounding the duodenum, forming a constriction at the junction of the second and third part of the duodenum, right? Often detected incidentally in asymptomatic patient, but the patient may be symptomatic, presenting with duodenal stenosis, post-bulbar ulcerations, pancreatitis, or biliary obstruction. These patients also have Down syndrome, the seen in Down syndrome. Later in life, a patient with annular pancreas later in life can present acute pancreatitis. If the block is above the ampulla, the patient presents with non-bilious vomiting and double bubble sign. We all know what the double bubble sign is when we talked about the obstructions. We'll talk about the neutral obstruction also. The double bubble refers to the bubble of the stomach and the bubble of the duodenal cap. So there are two bubbles there in a plane skygram. This double bubble sign is a sign seen on a plane skygram of the abdomen. And then you have the treatment. You can do a duodenal a duodenal or resection head of pancreas. We'll talk about this later. A bifid pancreas is a rare branching anomaly of the pancreatic tail and ductal system, where it becomes a bifid tail known as the fish tail. This I think we already talked about pancreativism, but just to highlight something out here, and that is that the usual presentation in these patients is the incidence is 5% autopsy, 10% in a patient of ERCP, MRCP series. That's the incidence, right? 25 to 30% of these patients present pancreatitis, acute or chronic. I told you failure of fusion. So if the minor papilla is small, or there is no connection out here, what is happening? There is an incomplete or inadequate drainage to the minor system, either leading to back pressure effect and acute pancreatitis, chronic pancreatitis, and if there is a blind ending duct. See this part C, blind ending duct. So there is nothing being secreted through this duct. So less of bicarbonate secretion out here. So let bicarbonate in the duodenum, less more of acid, less of bicarbonate. So the content of the acidity increases. So these patients can present with vulvar duodenal ulcers, right? The diagnosis is easily done on a ERCP, MRCP, EUS. Treatment, sphincterotomy, sphincteroplasty, or pancreatic or jejunostomy, or pancreatic head resection. Just one or two slides of pancreatic injury, then we finish the lecture today. You got the mechanism of pancreatic injury occurs at two ways. Number one, traumatic or iatrogenic. Traumatic, blunt trauma in the form of congenital laceration. You can have penetrating injury, like for example, a knife injury or gunshot injury. The most important thing is whether it is associated with or without ductal injury. So if there is ductal injury, the management differs. There is no ductal injury, management differs. The clinical presentation is an acute epigastric pain of variable degree. You'll have associated injuries, not only pancreatic, surrounding structure may be damaged, and the patient may or may not have cardiovascular instability. The investigation of pancreatic injury, the first thing to be done is a CT evidence. A serum amylase may be high and a serum lipase is also high, and in a scenario with a history of trauma it becomes significant. Okay, so serum amylase, if you have a traumatic injury, becomes significant. The treatment depends whether the patient is stable or unstable. A stable patient without peritonitis, don't do anything, just keep observing the patient. So the patient has got mild pain in the abdomen, there is minimal tenderness guarding, but the cardiovascular parameters are normal, don't do anything, observe the patient. But if the cardiovascular parameters are unstable, the blood pressure is not maintainable, the tachycardia is not maintained, the tachycardia keeps on increasing, does not come to normal tachy, to a normal pulse rate. So what do? You explore this patient. The patient has got severe peritonitis, explore. And the surgical options when you explore are very limited, are very highly morbid. That's why the dictum is try not to explore pancreatic injury unless and until it is essential. Why? Because managing a ductal injury is very, very difficult. Either you have to drain it, you have to repair it, you have to do a resection, or even a pancreatic duodenectomy, which requires a high level of expertise, and a general surgeon is not tuned in to go in for a pancreatic duodenectomy. So it's always safe for a general surgeon not to touch a pancreatic injury. If it requires exploration, refer that patient for a highly specialized unit. That's why pancreas is one structure which is still outside the domain of a general surgeon. A general surgeon usually does not try to touch the pancreas, right? Complications, pancreatic fistula in one third. See a very high morbid level. 33%, one third of these patients would turn out with pancreatic fistula. Or the patient may have ductal stricture at a later point of time, and these ductal strictures will present with recurrent acute pancreatitis. Or the patient will present with pseudopancreatic cyst. If it is an iatrogenic pancreatic injury, very commonly, the most common surgery where it is done is splenectomy. You've done a splenectomy, you were not careful, you ligated the splenic hilum, and ligating that, you also ligated a part of the tail of the pancreas. So this patient goes into postoperative pancreatitis. Or in a second operation, which is Billroth 2, where you're doing a partial gastrectomy, you go beyond the beyond the gastroduodenal artery, you touch on the centroid duct, which may be main duct in 7% of cases. And what do you like it? You like it the main pancreatic duct in that 7%. So please do not go beyond the gastroduodenal artery. Islet tumor enucleation, sphincterotomy, ERCP, post ERCP, or otherwise sphincterotomy. So all these conditions are iatrogenic incidences or evidences or instances where pancreatic injury can occur. Pancreatic fistula, the causes, trauma, postoperative complication, acute or chronic pancreatitis. The types could be internal or external. The most important part about managing a pancreatic fistula is the anatomical delineation of the fistula and the patency of the distal pancreatic duct. That means distal to the fistula. If it is patent, usually these fistulas will heal by themselves. But if it is not, if the patency of pancreatic duct is not there, then these fistulas will never heal. How do you diagnose a fistula? You can look at the amylase level in the drain fluid, or you can look at the lipase concentration in the drain, right? Or in the ascites. In either case, you'll have a high level of lipase or amylase concentration in the drain that you put in or in the acidic fluid. How do you manage these patients? Management is very difficult. The skin has to be protected. Why? Because pancreatic juice, it eats up or erodes the skin very early. Chemical dermatitis is very common in pancreas because remember it's got very high enzyme content. Fluoride correction is required. Remember how much secretion? 1.5 to 2 liters of pancreatic fluid per day. Treat the cause of the fistula. Why has it occurred in the first time? Parenteral or nasogeneal feeds. Drugs could be tried. Octreotide, which is somatostatin analog, reduces the fistula output and may facilitate patient fluid electrolyte management because less output, so fluid management becomes easier. The doses to be given 100 to 250 micrograms subcutaneously every 8 hours. And then if none of these work, then you can go in for stenting of the ductal system, hoping that the fistula will close by itself. So what are you trying to stent? The fistula? No, it's not stenting of the fistula. It's stenting of the main pancreatic duct. Or you can go in for a partial pancreatectomy, remove that part of the pancreas from where the fistula is arising. In either case, the fistula can be taken care of, but remember one thing, it is a highly morbid condition and can even be fatal in a number of instances. So that finishes the lecture for today. Thank you for your time. Next time we will be talking about a very, very important disease both for the surgeon and the physician, more for the surgeon, got a lot of surgical implications, and that is pancreatitis, both acute and chronic. Thank you.